Hello, everyone. Welcome to the part 2 of the UDS training today. My name is Megan Hiltner. I'm with JSI Research and Training Institute, Jon Snow, Inc. I joked about this the last time, not Jon Snow from Game of Thrones, but Jon Snow, the father of epidemiology. I'm a senior consultant at JSI, and I am just thrilled to be back with you today. For those of you that are new, I'll do my best to give you a bit of sort of a refresher or call back to some important key points from our first training. I would encourage you to go back and give it a listen if you can. I joked about this the last time. Put it at like 1.5 speed. I might have my chipmunk voice, but at least you can get through some of the content of that recording. During that first training, we went through an overview of the UDS, and we went through the reporting the patient profile, those demographic details. We also went through reporting clinical services. I shared with you a bunch of handouts and resources and called reference to those. I know Brandy also sent you a zip file with all kinds of stuff that's there to support you in your UDS reporting. I'm going to do that again today, and Brandy and I are going to tag team that. She'll chat out a bunch of links to things, but you should have a lot of those. And I really want, one of the major messages I want you to hear today again is you're not alone. There's a lot of resources there to support you in your UDS reporting. And I'll be also sharing at the end, again, highlighting a lot of those resources you can look to for getting questions. Today, we're going to cover the quality of care indicators. We're going to go into reporting operational and financial tables and other UDS required forms, as well as some tips for success. We're going to be taking a 10-minute break in the middle of the session, and then we'll start back up. During the last 30 minutes of the session today, my colleague Diane Lewis she is just a wealth of information on UDS and can really, tackle some really complex questions. She's going to be joining us for those sort of some Q&A. If you have some specific case examples or questions you'd like to ask, if we can't find the answer together during the training, Diane is going to be there for that time for that Q&A. So she'll join us at the very end. I'll also send out, or Brandy and I will also, together we'll share the link for an evaluation. We want your feedback. I know a lot of folks maybe filling out surveys left and right all the time, giving feedback, but we really do value that feedback. So you'll get that at the end here too. So with that, let's go ahead and get started. Oh, the other, thing is at any point, chat your questions in. I may just get through content and then pause and try and get to some of those questions. And I will commit to getting you an answer, whether that be at the time we do the Q&A and or following the training. I will commit to definitely getting you answers to your questions. But chat those in at any point in time when they come up. I welcome that. So with that, we left off with the clinical quality measures and tables, tables 6B and 7. As is the case for each year, the clinical quality measures are aligned with the electronic clinical quality measures. We're going to go into that a little bit here in a moment, but of note, I want to let you know, you seasoned folks that have been doing UDS a lot, I want you to know that 2 measures have somewhat substantive updates because of that alignment with the electronic clinical quality measures, but for the most part, they remain the same. So here is a list of the clinical process and outcome measures reported on the UDS. These are important because in addition to what services you provide and the diagnoses you treat, HRSA is interested, the Health Resources and Services Administration is interested in understanding the quality of care that was provided to patients. That's what the clinical quality measures are for. So HRSA has defined 18 measures that serve as proxy measures for long-term health outcomes. The measures can be categorized in these 3 broad categories. There's the screening and preventive care, the maternal care and children's health, and the chronic disease management. I want you to know that there were 90-minute webinars on each of these that dug deeply into these measures. And if you want to know more about reporting with regard to these measures and dig into that, I encourage you to listen to those webinars and go to HRSA's website or the Bureau of Primary Healthcare website. I'll show you where that resource is in a second. You can listen to those webinars. They really do dig in. But so these measures are divided across two tables in reporting in the UDS. There's table 6B and table 7. The tables look different, but really share the same basic structure. We're going to go over that. And the two measures that are highlighted in pink, so those are in the screening and preventive care column, they are the measures with notable changes in specifications. So just want to call those out at the start, just to have a heads up. That's the cervical cancer screening and the tobacco use screening and cessation services. Familiarity with the electronic clinical quality measures, the Eqms and their relationship to the UDS clinical quality measures is important for successful reporting. Here are just a few general reminders about that and why. So all health center patients who have one or more countable medical visit on table 5 that we went through during first training, except for the dental sealant measure, which requires a countable dental visit, are eligible for inclusion in the clinical quality measures based on the electronic Eqm specifications. So be sure to review the birth dates for any and all clinical measures. Some of the measures look at patients within a range as of the beginning of the year, while some of them look at the age of the last visit within the year. This can't be discerned from the name of the measure, so just be sure to look at the manual for those details. Another general reminder just to keep in mind is to be sure to review reports generated from your EHR along with the manual and the Eqm specifications. This is really important because while the Eqms provide detailed specifications for the measure, each EHR system is a little different in terms of how and where those required components need to be documented in order for the EHR to access and pull that information. So you'll need to be sure that your workflow and documentation in your system results in an accurate depiction. And this validation will be really important for your success. We're going to go into that in a little bit of detail. Those are just, I guess, some big picture reminders to have in your head. And another important, I guess, big picture general reminder as we get into these is to understand in this time of increased telehealth, many of the clinical quality measures, the telehealth visits make patients eligible for inclusion in the denominator. And this is decided by the measure steward for each measure. The general rule to follow is that if the telehealth visit meets a specific clinical quality measure's denominator and or numerator definition in that specification, and the UDS virtual visit definition as written in the Eqm and UDS manuals there, then it can be counted toward the measure. There is a really helpful handout that it's titled Telehealth Impact on UDS Clinical Measures Reporting that details this information for Eqm reporting in the UDS. And so check that out. And remember that each Eqm is defined by that measure steward, and the UDS report aligns with their instruction for inclusion or removal of telehealth in the evaluation of each component, the denominator, exclusion, and or numerator. So the telehealth impact handout really outlines that in more detail. If you want more info on the measure steward for each measure, it can be found in Appendix G of the UDS manual, and that's on pages 195 and 196. You can also direct specific questions or feedback about those specifications to the measure steward, and you can find directly that information in the manual. So first, let's take a look at Table 6B. On the screen under Format, in that table under Format, you're going to see the elements of the UDS clinical measures as they're reported when you're completing the UDS. So for each measure on Table 6B, you'll report column A, that is the denominator, or sometimes called the universe. Patients who fit the detailed criteria described for inclusion in the measure are here, and all eligible patients are reported in column A. Column B is the number of charts sampled or EHR total. In most cases, this will equal column A, as HRSA requires the reporting on the full universe of patients, meaning all patients reported in the denominator in column A, to every extent possible, so long as you can do so accurately. So that is what they're hoping for. If you cannot report the full universe of patients reported in column A, but you can report on 80% or more of the full universe, then that's the next best approach. In that case, you would report that number in column B. So an example of this is, say you switched EHRs in early January of 2021 and didn't port over some portion of information from your legacy system. And while your denominator in column A is, say, 5,000 patients, maybe there were 120 patients that you weren't able to access information because that information wasn't brought over into the new system successfully. So in that scenario, you'd report the 5,000 in column A, and then you would report 4,880 in column B. You should only report this way if, one, there's no feasible way to access that patient information to report on in the full population in column A. Or two, if the patients not included do not bias the sample. So for example, not including patients who are homeless or seen in the mobile clinic, that would be unacceptable, as it would bias the sample. So if neither of these two options are available to you, you may also report a randomly selected sample of 70 records from the universe. Just note that chart sampling is really the last resort, and this option may not be available in the future. If you report any clinical measure using either the 80% option or the sampling of the 70 charts option, the full denominator, population of patients who meet that criteria, must still be identified and reported in column A. So in column C, that's the report of the number of patients included in column B whose records demonstrate that they meet the requirements of the measure. So this is also called the numerator, and I'll use that term numerator many times here going forward. It just means that among those being reported on from the denominator, they meet that particular measure requirements. So now let's shift our focus then to the other side of the screen for a couple more key definitions. For most measures, there are exclusions and or exceptions. These are patients who should not be considered for the measure or included in the denominator. Just note that this year, there is some clarifications about exclusions and exceptions, or patients who meet exclusions criteria who are always to be excluded from the denominator. Patients who meet that exception criteria can be assessed for whether they meet the numerator specifications. And if they do, then they can be included in both the denominator and the numerator. If they don't meet the numerator criteria, but do meet an exception criteria, then they could be taken out of the denominator. Most of the clinical process and quality measures align with the Eqms, but some measures have specific considerations that you need to take into account when determining whether patients should be included in the universe of patients or they meet that standard. And these are detailed in the UDS reporting considerations section of each measure in the UDS manual. So table 7, it really follows the same 3-column format: that denominator, charts reviewed, and numerator structure as we just discussed in table 6B. The descriptions that were discussed on the last slide pertain here as well. The difference is that between 6B and 7 is that table 7 is reported by race and ethnicity. So it's not just the 3 numbers, the denominator, charts reviewed, and numerator. It's those 3 numbers for each race and ethnicity for which your health center has patients included in the measure. So all patients who meet the inclusion criteria for the measure are reported on this table by their race and ethnicity. 3 measures are reported on this table. Those 3 measures include deliveries and birth weight. We'll go into that in the pre and perinatal section here in a bit. The controlled hypertension measure and uncontrolled diabetes. So Note that as with Table 6B, the expectation is that these measures will be reported based on complete and accurate information, and that every effort will be made to report on the full population of eligible patients. And again, although that 80% method is permissible, HRSA is really hoping that the 100% universe reporting is the method that you are using when possible. Awareness and understanding of the Eqms or the clinical quality measure specifications is really important. Eqms are designed to be reported from an EHR. The health quality measure format, HQMF, is used to format the ECQM content using the data model, the quality data model, the QDM, to define the data elements and the clinical quality language, or the CQL, to express the logic that's needed to evaluate a provider or an organization's performance. I feel like I just spouted out a bunch of acronyms and it just rolls off the tongue, right? But I guess the key takeaway here, or takeaways, are that an ECQM that is specified in a standard electronic format and is designed to use structured encoded data present in the EHR. And the ECQMs are used because they're standardized at a national level. And they're designed to be reported from EHR, which reduces the burden on each individual organization to interpret and implement each measure. But it does require familiarity with the standard requirements and taking steps to really ensure that documentation aligns with those standard requirements is what will help in this process. So again, just be sure to review the reporting guidance from your EHR in addition to the UDS manual and the ECQM specifications. While the ECQMs provide measure specifications, each EHR system can be a little different. Again, I mentioned that earlier. In terms of how and where those are reported, the reported components need to be documented in order for the reports to see or include that information. And it's important to HRSA and presumably to you to get credit for all that hard work you do and the services you provide to your patients. And so documenting those where and how your system, it will support that. In essence, for all of that reporting to happen and you all to get credit and for HRSA to see this. So if this is new to you, and there was a detailed description on how to navigate this in part 1 of the clinical measures series, which was held on September 23rd. And that was a webinar, and you can access those slides and a recording on HRSA's UDS resources site and listen to that and get into more detail on that. Another key note here is the ECQMs are a detailed criteria defined by the measure steward. So again, like that measure steward, for example, in CQA or some other organization, that it is determined by the measure steward and not determined by HRSA or the UDS. So there are likely some aspects of these measures that are different from your workflow or that some clinicians may not agree with, but these are standardized at the national level. So they do need to be reported per these requirements. But that's all to say that the reporting needs to align with the requirements, but care does not need to change. So now we're going to move into reviewing the clinical quality measures. As a quick summary, I mentioned this when I showed you that table of all the measures. 2 measures in Table B had notable updates to their ECQM. That's tobacco use screening and cessation intervention and cervical cancer screening. But there are no new clinical quality measures reported in the UDS for calendar year 2021, just some updates. We're going to go through each now. Some we skip over because I want to get into more detail, but we're going to go through them as line by line in order. If you you again, go to your UDS manual when you begin to dig in, and you can really, really research them in more detail as well. This table shows the current version of the measures, and be sure to use that most current version that is, for example, linked in the UDS manual, or you can go to the ECQM Resource Center and check into those. Some measures like IBD, ischemic vascular disease, and dental sealants have been retired or don't have new versions, but they are still used for the UDS. And the version that should be used is specified here, as well as in the manual and the clinical measures handout that you received at the with all the materials for this training. While the measures generally align with ECQMs, there are some differences in the UDS measures, as I mentioned. So review the UDS considerations heading under each measure in the UDS manual for those details. Those considerations are intended to ensure continuity in data from UDS across the years. And you can refer to the clinical quality measures handout that's linked. It's here in this slide. I believe, and Brandy chatted that out. You can refer to that for helpful details. In the next few slides, it's going to follow the same structure, and we'll review each measure briefly. If you have questions, drop them in the chat. But also note that you can email the helpline they're available year-round with questions as well. So, you can put your questions in the chat. We can talk them through here. But know that when you start digging in, that help is available to you. All right, so the first section of Table 6B is prenatal patients by age and trimester of entry. That's one we're going to get into more detail in a moment. Let's move to line 10. Line 10 on Table 6B is childhood immunization status, which measures the percentage of children 2 years of age who have evidence showing they've received specified vaccines or met one of the exclusions or exceptions by their second birthday. And those vaccines are listed here on this slide, as well as detailed in the manual. A couple of frequently asked questions on immunization status. You'll include children in the denominator for whom no vaccination information is available and or who were first seen at a point when there was not enough time to fully immunize them prior to their second birthday. You'll include children who had a contraindication for a specific vaccine in the denominator. You'll count them as being compliant for that specific vaccine if the guidance permits, and then review for the administration of the rest of the vaccines. In line 11, cervical cancer screening, that captures women 23 through 63 years of age in 2021 who had a medical visit in 2021, who also received one or more of the specified screenings for cervical cancer. Between 2020 and 2021, there is a change in the cervical cancer screening measure, and we'll talk through that here in a sec. On this slide, first measure here, line 11A, still on Table 6B. This is breast cancer screening, which measures the percentage of women 50 to 74 who had a mammogram to screen for breast cancer in the 27 months prior to the end of the measurement period. A couple of clarifications and tips for reporting on the breast cancer screening measure. For this measure, you'll include and evaluate patients according to sex assigned at birth. Next, you will not count biopsies, breast ultrasounds, or MRIs, because according to the measure specifications outlined by the measure steward, they are not appropriate methods for primary breast cancer screening. On line 12, weight assessment and counseling for nutrition and physical activity for children and adolescents, colloquially known as the child BMI and counseling measure. This looks at the percentage of patients 3 to 17 years of age who had an outpatient medical visit and who had evidence of height, weight, and BMI percentile documentation, and who had documentation of counseling for nutrition, and who had documentation of counseling for physical activity during the measurement period. Line 13 is the BMI screening and follow-up plan, again, colloquially known as the adult BMI and follow-up plan measure. This measures the percentage of health center patients aged 18 years and older with BMI documented during the most recent visit or within the previous 12 months to that visit, and who had a follow-up plan documented if the most recent BMI was outside of normal parameters. For this measure, if a patient has only had a telehealth visit in the year, they are not eligible for inclusion in the denominator. This is different from almost all of the other clinical quality measures. You can review the telehealth impacts handout for more details on that, but in essence, it says that this screening measure requires therapy, treatment, or assessment that cannot be conducted via telehealth. To meet the numerator requirement for this measure, the most recent high-low BMI has to be documented during the qualifying encounter or during the previous 12 months. However, the follow-up plan and intervention for the most recent high-low BMI must be on or after the most recent high-low BMI. This is detailed in the clinical quality language, the CQL logic, and is different from the UDS manual and the Eqms specification. This change is likely to have an impact on the number of patients who meet the requirement, so just want to note that. For the tobacco screening measure on line 14A, it looks at the percentage of patients 18 or older screened for tobacco who receive cessation if identified as a tobacco user. There is a change from 2020 to 2021 to this measure, which I'll go into in detail in a moment here. The statin therapy for the prevention and treatment of cardiovascular disease reported on line 17A of 6B measures the percentage of patients defined by the measure at high risk of cardiovascular events, age 21 years and older, who were prescribed or were on statin therapy during the measurement period. This is a complex measure, so I highly recommend reviewing the Eqms specifications and the Eqms workflow to get a better handle on this one. It was covered in detail in a part 3 chronic disease measures webinar. That one was held on October 8th. Again, in the resources that are being shared, and I'll share again at the end, I'll call your attention to that if you want to really dig in there. But for the numerator, one critical note is that statin therapy must be through the end of the year. So the patient must have received an order or a prescription that goes through the end of 2021. A prescription in 2020 that covers most of 2021 that is not reordered or refilled by the clinic will not meet the measure. The prescription has to go through the end of the year. On line 18 of table 6B, report the ischemic vascular disease, IVD, the use of aspirin or another antiplatelet measure. So note that the electronic specifications for this measure have not been updated. So you'll continue to follow the same specifications for UDS reporting as done in previous years. This measure looks at patients 18 years of age and older with a medical visit in 2021 who had an AMI, CABG, or PCI during the 12 months prior to the measurement period, or who had a diagnosis of IVD overlapping the measurement period, meaning the diagnosis of IVD that existed in 2021, who had an active medication of aspirin or another antiplatelet during the measurement period, again, meaning during 2021. Line 19, colorectal cancer screening has been updated to align with the most recent Eqms, but does not have substantive changes. It measures the percentage of adults 50 to 75 years of age who had appropriate screening for colorectal cancer. HIV linkage to care reported on line 20 of table B does not have a corresponding Eqms. This measures the percentage of patients newly diagnosed with HIV at the health center who were seen for follow-up treatment and linked to care within 30 days of that first diagnosis. Just know that this is limited to patients diagnosed for the first time ever If they have ever received a diagnosis of HIV before, then it's not their first ever diagnosis, then they would not be included in the denominator for this particular measure. Line 20A is the HIV screening measure, and this was new last year. This measure aligns with the Ecqms, and it looks at the percentage of patients who received at least one HIV test between their 15th and 66th birthday. Note that this measure can have a very long look back period. So access to historical information like tests or lab results is really key for success on this one. Screening for depression and follow-up plan is reported on line 21. This measure looks at the percentage of patients aged 12 and older who are screened for depression on the date of the visit or 14 days prior to the visit using an age-appropriate standardized screening tool, and if positive, had a follow-up documented on the date of the visit. In the denominator, you'll include patients 12 years and older with at least one medical visit during the measurement period. Next up is line 21A, depression remission at 12 months, which was new last year. And I know it has been a bit of a bear for some health centers. The denominator reported in column A is patients aged 12 years and older with a diagnosis of measured depression or dysthymia and an initial PHQ-9 or PHQ-9M score greater than 9 at an index event between November 1st of 2019 through October 31st of 2020, and at least one medical visit during 2021. So this means that this is looking back quite a ways in your system to identify that index event, which is a visit at which the patient had both a diagnosis of major depression or dysthymia and a PHQ-9 of greater than 9, then determining if that patient with that index event also had a visit in 2021. So those together comprise the denominator. Then looking at that period, that is 10 to 14 months from that index event, to see if the patient had a PHQ-9 of less than 5. Last on this slide is line 2022 of table B. This measure is the dental sealants measure, which measures the percentage of children age 6 to 9 years at moderate to high risk for dental caries who receive dental sealants on their first permanent molar during the measurement period. Few notes: the dental sealant Ecqms specifications have not been updated. Version 0 should continue to be used. And this measure is a little different in that dental patients are eligible for inclusion, while other measures are limited to medical patients. So let's move on to what we sometimes call the outcome measures. These are reported on table 7. And remember, these are the ones broken down further by race and ethnicity. Section A of table 7 is deliveries and birth weights. And we'll get into that here in a sec. But section B of table 7 is controlling high blood pressure, which measures the percentage of patients 18 to 85 years of age who had a diagnosis of hypertension overlapping the measurement period or the year prior, whose most recent blood pressure was adequately controlled or less than 140/90 during the measurement period. This measure includes patients who have an active diagnosis of hypertension, typically meaning the diagnosis of hypertension on the problem list that has not been resolved, even if their medical visit during the year were unrelated to the diagnosis. Of course, patients with visits where they receive treatment for their hypertension diagnosis are included too. I believe somebody asked this in the registration questions for even the start of the training about remote patient monitoring. So remote patient monitoring is permissible if the data is transmitted directly from the patient's device to somewhere that a provider can see it, or if the provider sees and records blood pressure taken by a patient's remote device in the patient health record. So use the last day a blood pressure reading was taken and recorded in 2021 to determine if the specified measure requirements are met. If there are multiple readings on the last day, use the lowest systolic and lowest diastolic reading. Blood pressure readings can be during a non-medical visit. So, for example, a blood pressure reading from a dental visit could meet the numerator requirements. Section C captures diabetes, hemoglobin A1C port control, which is measured as a percentage of health center patients age 18 to 75 with diabetes who had hemoglobin A1C greater than 9% or no test during the measurement period. Note that the third column, or column 3F, is patients whose diabetes is uncontrolled, as demonstrated by an A1C greater than 9, or who did not have an A1C recorded in 2021. Just note that a lower rate is better for this measure, unlike the other clinical quality measures. There is a handout that is available on this, and you can check that out. Let's move on a little bit further here, and then we'll take a pause. And so let's look at the two measures with those substantive changes that I mentioned. The cervical cancer screening measure has been updated by the measure steward for version 9. The first change is the rephrasing in the description from women age 30 to 64 who had HPV testing performed every 5 years so it was testing performed every 5 years to within the last 5 years. This is not a change to the actual logic, but it is intended to clarify that this is not looking at sequential 5-year period, but rather just the last 5 years. The second change from the measure steward updates the numerator to align with the most recent clinical recommendations. Now the second numerator criteria is shown in this slide in the bottom right side is the cervical HPV testing performed during the measurement period or the 4 years prior to the measurement period for women who are 30 years or older at the time of the test. The other measure with substantive changes is the tobacco use screening and cessation intervention measure. And it was updated by the measure steward. The denominator is unchanged. Still, patients age 18 and older, so birthday on or before January 1st, 2003, seen for at least 2 medical visits in the calendar year, or at least 1 preventive medical visit during the measurement period. That would be the denominator. The change is to the numerator, which is it now requires assessment within 12 months rather than 24 months, and no longer requires that the intervention needs to come after the most recent assessment. So now the cessation counseling or intervention just needs to be during the measurement period, meaning during the calendar year. We've tried to document these changes in the slide. So if you refer back to them, you can go back and refer to them and if as needed. And here are a series of resources you can go to for additional information about the clinical measures. I do highly recommend those 3-part clinical quality measure series of webinars if you're looking for a deeper dive. I know there's a lot here. And I did see a question. Let me see if I can answer it here. If not, I can devote brain power to it at our break. So Mary, you're asking, can a blood pressure reading done during an MA visit count, even though that's not a billable visit? Let me double check that. Because I want to make sure I give you the right answer, but I'll get the answer during the break and I'll share it back with you, Mary. Okay, let's keep plugging along here. So summary of some do's and don'ts that will help hopefully bring this home for you with regard to these tables. Some do's. Do know that we all know that COVID has created a whole host of new situations and realities for y'all to navigate. And it just, I want you to know that we appreciate that. And the reporting requirements of the UDS are mostly do remain the same to support continuity and just to adhere to longstanding requirements. Be sure you're reporting all measures for which you have eligible patients, even if none of your patients meet the measure requirements. This means that the denominator needs to be identified for all relevant measures. Be sure to review the requirements, including the look back periods, the exclusions, exceptions, and for those two tables, table 6B and 7. Do be sure that reporting for table 6A is limited to health center patients. Some don'ts now. Don't forget that the tobacco screening and cessation intervention measure has a shortened time frame, so from 24 months to 12 months. And there may be a drop in compliance related to this, particularly if your processes have not been updated. Don't exclude patients who meet the denominator criteria unless they meet specified exclusion or exception criteria. And don't try to interpret age or other aspects from the measure title. Try and really apply those, the specifications defined. So let's do a quick poll here. Brandy, if you can help me with that, just sort of check to see if the information sunk in. So the poll here is asking which measures listed here, you have a single choice, are new this year. New. So is it breast cancer screening, HIV screening, depression remission at 12 months, statin therapy, all of these or none of these? Which measure is new or are new? And you can close the poll whenever, Randy, if you're thinking a few folks have chimed in to play the trivia game. And most of you are right. The answer is none of these. So none of these are new, just a few updates. The tobacco screening and cessation and the cervical cancer screening is new. So no new, just some updates. So there were a couple that I kind of said multiple times, okay, we're going to get to these, we're going to get to these. We buzzed through it. Now we're going to try and dig in a little bit more on the prenatal care and birth outcomes measures. Table 6B and 7 capture prenatal care and deliveries and birth outcomes. Table 6B is the prenatal care, deliveries, and birth outcomes, table 7. Reporting these sections requires including health center patients who initiate prenatal care within the health center or its referral network. All health centers are required to report these sections, even if prenatal care is only provided by a referral. Prenatal care initiated with the health center or its referral network refers to prenatal care provided in any of the following ways. Prenatal care initiated with the health center directly, such as an OBGYN who works at the health center, or prenatal care initiated with a provider or entity with which the health center has a formal referral contractual agreement with, as recorded in column 2 of Form 5A. Or a prenatal care is initiated with a provider or entity with which the health center has a formal written referral arrangement, as recorded in column 3 of Form 5A. So you'll want to review your Form 5A, which details services provided under your health center program grant to determine what this means for your health center. Remember, prenatal care and related delivery and birth weight outcomes must be reported from all 3 of these scenarios listed above. Therefore, tracking systems must be in place for all 3 if applicable to your clinic. This also includes both patients who are referred for all of their prenatal care as those who are referred to a high-risk provider. For example, care and outcomes, I guess that is the example. So care and outcomes need to be tracked and reported for all health center prenatal patients. The prenatal and birth outcomes measures are reported across 2 tables. It's really important to understand that they're related to each other. So really, it helps to kind of look at these two together. On table 6B, report your prenatal care patients by age and trimester of entry. Remember that pregnancies cross years, and you'll need to include, as such, those prenatal patients. So patients who began prenatal care in the previous year and delivered in the current year, patients who began prenatal care and delivered in the current year, and patients who began prenatal care in the current year and will not deliver until next year. Those all need to be captured in table 6B. On table 7, you'll report the number of prenatal patients who delivered, as well as the live births that resulted from the deliveries. It's important that even if the health centers do not do prenatal care themselves, they still need to track and report table 7 outcomes for all their patients who tested, found positive, and referred out. And delivery and birth outcomes, like birth weights, can be received from the hospital or the delivering provider, or self-reported by the patient. As a health center, you're required to provide prenatal care either directly or through referral. If you provide prenatal care only through referral, you'll check the box for referral only. As I mentioned a couple of slides back, health centers must track and report on all prenatal patients, whether they provide the care or they refer out. You'll report your total number of prenatal care patients served during the year, even if only for delivery, by their age in section A. You'll report patient's age as of June 30th for lines 1 through 6. You'll also report the same group of prenatal patients by the trimester in which they began prenatal care and whether they started their care with you or with another prenatal care provider. Column A captures patients who started prenatal care with your health center, whether provided within your health center or through referral from your health center. Referring the patient out for prenatal care still counts as starting with you if that was the beginning of their prenatal care. Column B refers to patients who start with another provider and transfer into prenatal care with you, your care. Patient totals on line 6 and the sum of lines 7 through 9 must match. Prenatal care, quote unquote, begins for the purposes of UDS with a comprehensive prenatal exam. Trimester is determined using the last menstrual period and the LMP, and there in the glossary of the UDS manual, there's definitions about that if you need to look that up. A subset of your prenatal patients will deliver during the year. Those deliveries and related birth outcomes are reported on table 7. In column 1A, you'll report the number of prenatal patients who delivered by their race and ethnicity, regardless of outcomes. This would include stillbirths, you would include stillbirths, but you'd exclude miscarriages. If someone delivers multiple births, you'll report one delivery. Column 1A talks about the patient who delivered, not the resulting baby or babies. Columns 1B through 1D report all live births by their birth weight and race ethnicity. Column 1B and 1D report on the child or children and race ethnicity, which may be different than that race of the prenatal patient who delivered. Race ethnicity of a child is self-reported by the parent. Report race with no ethnicity as non-Latino or Latina. Birth weights of multiples are reported separately. The 3 birth weight categories are listed on the slide, but they include very low birth weight, that's column 1B, that's less than 1,500 grams. There's low birth weight, that's column 1C. It is between 1,500 and 2,499 grams. And normal is column 1D, and it's greater than or equal to 2,500 grams. Each health center is required to follow up with prenatal patients who are referred out to your health center for prenatal care for any reason to determine delivery and birth outcome. Delivery and birth weight information can come from a hospital or the delivery provider or the patient self-report, as I mentioned that earlier. Also on table 7, you'll report the number of pregnant women at your health center who are HIV positive, regardless of whether or not they were part of your prenatal care program. This is just the count of patients who have HIV and who are pregnant. You will also report the total number of deliveries performed by your health center providers, include deliveries of women who are not health center patients if your providers participate in rounding at a hospital. Note that delivered by your provider here means that your health center paid for them. So you would not include deliveries that providers bill for and collect on for themselves or any sort of moonlighting that they might do. Those deliveries are outside of your health center scope. So you wouldn't report those here. Okay, so just a couple of case scenarios to try and bring this home. Let's look at tables 6B and 7 for this knowledge check. And if you want to look at your tables, you can in sort of trying to answer some of these questions. The question is, where are these patients reported in the prenatal section? So the first patient is a 23-year-old patient was seen on December of 2020 for a prenatal care in the health center. The patient then delivered a 2,750 gram baby on January 13th of 2021. So that's one scenario. And let me read the next scenario, then we'll talk through both of them. Okay, so another patient, a 32-year-old patient is seen at the health center in early 2021. The patient has a pregnancy test and is found to be pregnant. The nurse gives the patient a list of nearby prenatal care providers who are accepting new patients. The patient is seen again at the health center in 2021 for allergies and a COVID test. At that visit, the patient has a new baby in tow. So let's look at both these and think about how they would be reported. The first patient, I don't know if you're following along in your tables, but so the first patient, the 23-year-old patient seen in December and for prenatal care, and then had the 2,750 gram baby on January 13th. This patient would be reported in these sections. On table 6B, as a prenatal patient by age, and then trimester of entry. And note that this is true even though the patient only delivered in 2021. So this patient's also reported as a delivery on table 7, column 1A by race ethnicity. And then the patient's baby would be reported in column 1D by their weight and greater than 2,500 grams and by the race ethnicity of the baby. So if you were looking in your tables, that's where all the places where that patient would be reported in the prenatal sections. Okay, so the second patient, this second example, the patient, though they were pregnant and had a baby, they did not receive prenatal services from the health center or its referral network. Remember, they were just given a list of providers that were accepting new patients. So therefore, they would not be a prenatal patient. And so they would not be reported in the prenatal section of 6B, nor would a delivery or birth weight be reported in table 7 for this pregnancy baby. I think this is just trying to call attention to a couple of scenarios that could happen and connect them to those tables. So some do's and don'ts regarding the prenatal birth measures tables. Do include patients still pregnant at the end of the prior calendar year in the current calendar year prenatal and delivery, considering evidence of a delivery, which remember can be from the provider, hospital, or the patient. Do report all prenatal patients, whether you provide the prenatal services within your health center or refer out for these services. Do report each baby in the live births by birth weight columns on table 7. This means with twins, you report 2 babies for 1 delivery. Some don'ts. Don't report health center patients who are referred out for prenatal care in column B for trimester of entry into prenatal care on 6B. Report in column A instead. Don't report patients as having delivered during the reporting period when there's no evidence of delivery. And don't forget to track delivery outcomes with prenatal care patients, even if they transferred out of the health center. And like this is mostly seen among high-risk patients. Just some tips from to help you in this. All right. So with that, I want to break this up about halfway through. Why don't we take our 10-minute break now? Because next we're going to get into the financial tables. So it's 58 minutes past the hour right now. Why don't we round up and take a 12-minute break and come back at 10 minutes after? So it's 9:58 there. Let's come back at 10:10. Is my clock right, Brandy? Or my time zone translation? Good. So everybody, if y'all can come back at 10:10, we'll get our brains right for the financial tables. And Mary, I'll respond to your question in the chat box. Well, welcome back, folks. I hope you had a few minutes to step away or to just recharge your brain. And I hope you're hanging in there with me. Mary, I chatted in a response to your question, and I even pulled some helpful stuff from the manual too in the cases where blood pressure ratings should not be used. To your question, yes, you can use the reading done during an MA visit as long as it's the most recent visit, but the scenarios where the manual did say where blood pressure readings should not be used toward that measure would be taken during an acute inpatient stay, an ED visit, same day as a diagnostic test, or reported by the patient. So folks, again, use the chat box. I'll do my best to get you that information back, and we're just going to keep plugging through here. So now with the financial tables, these tables demonstrate how the health center provide high quality services to our patients. So what does it cost to provide the services detailed elsewhere on the UDS report to the patient? What revenues do you have to pay for the work? These financial tables, though, do not present a full or traditional picture of a health center's net operating performance and financial condition. That's not really the role of these tables. Health centers and HRSA and others properly rely on the audit reports and financial statements to gain a better understanding of an organization's financial operations and well-being. Health center program is used the Office of Federal Assistance Management, OFAM. They use these resources to conduct its financial oversight of health centers. UDS financial data provides other useful and relevant information that's not available for comparison purposes from either the audits or the financial statements. So through these tables, you and all audiences of the UDS can understand diversification of funding, dependency on the Bureau of Primary Healthcare funding. You can understand the degree to which you maximize patient revenues. You can look at competitiveness of costs and overall surplus or deficit. So here's a big overview of the tables we're going to be digging into. Table 8A, it collects the total costs of all activities attributable to the calendar year that are within the approved scope. Table 9D collects patient service revenue, including charges, collections, and adjustments attributable to the calendar year. Table 9E collects revenue related to non-patient receipts, including grants, contracts, and other funds related in that calendar year from sources within the scope of the project. That's just sort of high level overview of what each of the tables we're going to get into cover. So table 8A. This table 8A presents cost data by service area or cost center and does so on a full accrual basis. If costs were incurred in 2020, then they're reported on table 8A. Cost centers are uniformly defined, which permits comparisons that would not otherwise be available from traditional financial statements. The cost centers on the UDS are listed in the first column here, and they align with table 5. You can see a detailed crosswalk on that on page 174 of the UDS manual. On table 8A, these cost centers are lines 1 through 15. And the distribution of costs allows the program to better identify how its resources are consumed, individually and collectively. There are 21 cost centers on table 8A, which gives a thorough description of how the resources are spent across the health center to provide the health center services. Column A is where you'll report the accrued costs for each cost center. Accrued costs include personnel, benefits, supplies, equipment, depreciation, travel, etc. for that cost center. So for example, dental personnel and their fringe benefits, dental supplies, dental equipment, and depreciation of capital dental costs would be sort of included in that cost center. Facility and admin costs are reported in column A on line 14 and 15, and then allocated as overhead in column B. In this way, table 8A provides a uniform definition of overhead. The result of reporting costs in this way are total costs by cost center. And they're reported in column C of table 8A and automatically calculated by the EHBs, which represent a total cost to provide the services in that area, and then can be used to calculate things like cost per visit or cost per patient. This is why that crosswalk between table 5 and this table are really important in order for something like a cost per visit to be accurate. The visit and costs need to be reported consistently. There aren't changes from last year on this, though you may want to take a look at the UDS manual to refresh your memory on how that looks. But just if it is peace of mind for some folks that have done this year after year, there aren't changes since last year. So I mentioned a moment ago, and if you attended the last session, here's a review of table 5, and also table 8A is listed on here. So on the left side of this screen, you have a snippet of table 5. On the right, a snippet of table 8A. The total costs for everything provided by the FTEs reported on lines 1 through 15 of table 5 are reported on lines 1 through 3 of table 8A. We'll dig into that a little more here in a moment. Similarly, the total costs related to dental on lines 16 through 18 of table 5 are reported on line 5 of table 8A. If you have different folks completing the sections of the UDS, like HR is doing FTEs and financial folks are doing these tables, this is a good way for you all to sort of see how they connect and how you all may want to connect in your completion as you work together. So let's take a closer look at the cost centers, which are the lines of table 8A and what goes into each. Medical is one of the only cost centers where you're asked to subdivide costs. You will separately report personnel, lab, x-ray, and other direct costs. Be sure that the costs related to FTEs on lines 1 through 12 of table 5 are reported on line 1 here. Vouchered or contracted medical services are also reported on line 1 of this table. Lab and x-ray personnel from lines 13 and 14 of table 5 are reported on line 2. Remember, this is only medical lab and x-ray personnel costs. You wouldn't report dental lab and x-ray here or retinography. So don't report other medical costs here like equipment. That would go on line 3. Other direct costs like supplies, equipment, EHR costs, and other costs, essentially the non-personnel medical costs incurred by your medical department, are reported on line 3. The other cost centers that subdivide costs is pharmacy, where on lines 8A and 8B, you also separate drug costs reported from line 8B from pharmacy costs reported on 8A. You'll report dispensing fees on 8A because remember, only pharmaceutical costs go on line 8B. One note here is that pharmacy assistance programs are not reported in the pharmacy cost center. Those are reported on line 11E, eligibility assistance. All other cost centers costs are reported in sum and include direct expenses, including personnel, hired or contracted, benefits, supplies, and equipment and depreciation. These are all reported on lines 5 through 13. Excluding 8A and 8B. Again, I encourage you to review that crosswalk on page 174 of the UDS manual for exactly where each line of table 5 mapped to 8A. 2 other notes on line 12, other related services includes space rented out within the health center. It also includes WIC, retail, pharmacy to non-pharmacy, to non-patients. And line 12A, quality improvement, includes the personnel dedicated to HIT, EHR design, and quality improvement. So we touched on some of this on that last slide, but I want to highlight pharmacy reporting here because I know in the last training, some folks brought up 340B. So first, if you have a contract or a 340B pharmacy, you'll want to review pages 166 and 167 of the manual for reporting requirements. Some other key tips here. Dispensing fees are reported on line 8A. Pharmacy, along with costs of any pharmacy personnel and any non-drug pharmacy costs, are also on 8A. Only the costs of pharmaceuticals are reported in 8B, whether dispensed through an in-house pharmacy or contract pharmacy. If there are non-clinical support staff who support the pharmacy program, such as a 340B manager, then the cost of those personnel should initially be reported on line 15, column A, non-clinical support, and then should be allocated to line 8A in column B as pharmacy-specific overhead. So as mentioned, pharmacy assistance programs are an enabling service and therefore should be reported in the enabling section, specifically on line 11E. Donated pharmaceuticals are reported on line 18, donated facilities, services, and supplies. So let's discuss how to report on your overhead, such as indirect costs. That's facility and non-clinical support or administrative costs. In column A, you'll report the following. Line 14, facility. You'll report all facility-related expenses, including direct personnel costs, rent, depreciation, mortgage interest payments, utilities, security, groundskeeping, janitorial services, maintenance. Do not report gross facility costs for principal payments on this line, just depreciation and interest payments. On line 15, non-clinical support. This line report costs of all personnel reported on on table 5, lines 30A through 30C and 32, including corporate administration, billing, collections, medical records and intake personnel, facility and liability insurance, legal fees, managing practice management systems, direct non-clinical support costs like travel, supplies. The total of these 2 lines is reported on line 16 and represents the total indirect costs that will be allocated as overhead in column B. So total indirect costs comprised of facility, which is line 14, and non-clinical support, line 15, are then allocated across the cost centers in column B as overhead. And you can use whatever allocation method you want or find to be most accurate, but it's important to allocate overhead in a way that represents the true cost of your service areas. For example, service areas that are contracted out or take far less facility space may have less allocation, overhead allocation. One recommended approach for allocating overhead is that you start with your facility costs for each of your sites, and then you determine the service area's use for each site. So for example, site A may have $10,000 worth of costs, and by 75% used by medical and 25% used by mental health. That would give you $7,500 in facility overhead for the medical and $2,500 in the facility for mental health. If you do this for all your sites and document the facility overhead for each service area, including non-clinical support, it's one method to consider. Then allocate non-clinical support costs that are clearly used by a single service area, such as a dedicated front desk staff or a 340B manager, as mentioned earlier. Then you can distribute the remaining non-clinical support costs and any shared space costs allocated based on the distribution of those direct costs. The key is to not simply divide total overhead by the number of cost centers or allocate in some other one-step way that doesn't reflect the true cost to operate each department. That will skew your calculations. If you want a deeper example of this, you can access the slides in the recording from an October 14th webinar on that HRSA UDS resource page. There's an in-depth example in that webinar on how you can allocate those costs. Table 8A, line 18 is where health centers should report all non-cash donations. This includes in-kind services like donated facilities or supplies and pharmaceuticals and volunteer hours. Be sure that no cash donations are reported here. Cash donations are reported on Table 9E. There is a resource in your materials if you want to see some examples of this. Those are the materials that were sent out at the beginning of the training with your in that zip file. All right, so moving on to Table 9D, patient service revenue. This captures all of the health center's patient service generated charges and revenue. This table is all patient service generated income in the calendar year. Other revenue that is not directly tied to patient services is reported in Table 9E. So together, Tables 9D and 9E comprise all the revenues that support your health center's scope of services. Reporting in this table do not follow generally accepted accounting principles. This table really seeks to capture the total value of services provided to patients and revenue received for those services. Both revenue tables, Tables 9D and 9E, are reported on a cash basis, which means you're only going to report the actual dollars you received during the calendar year. The charges or charges incurred during that calendar year as well. This table, Table 9D, can look a little overwhelming. There's lots of rows and columns, but really it's the same basic premise repeated for each payer. You'll report charges, collections, supplemental payments, contractual adjustments by payer and by form of payment. So meaning non-managed care, capitated managed care, fee-for-service managed care for each. On this slide, you can see a portion of the table demonstrated what I just mentioned. So this portion of the table shows that lines 1 through 2B are all Medicaid and just broken out by form of payment. Then you just go along the column, starting with line 3, you move on to Medicare and you do the same thing. And then it repeats. Note that you'll report revenues from fee-for-service programs like breast and cervical cancer programs or indigent care programs as other public revenue, though you do not report these patients as being insured by other public. The next slides follow the order of the graphic at the bottom of this page. So first, we're going to talk about the columns, charges and collections, and then we'll talk about payers, and then we'll talk about payment. Column A, report full charges, meaning the total billed charges across all services reported by payer source, which are the rows. Charges are reported in column A based on the health center's fee schedule, regardless of how the service was reimbursed. Any and all charges for services provided in 2021 are reported in column A. These are undiscounted or unadjusted gross charges for services. Don't take off the amount you're paid, and don't take off any discounts or slides that your patient get. This is all covered in the other columns. So the health center should not use payer codes or negotiated rates as charges. The health center compliance manual specifies that the charges are to be in accordance with its fee schedule. Each health center should be using CPT or HCPCS codes that identify the services provided in a visit, and they must use the health center's fee schedule charges only when reporting charges. Guidance for separating payer charge rates from the health center charge rates are included with question 7 of table 90 FAQs in the UDS manual. So that's a helpful resource if you get hung up here. Be sure to include all service charges, for example, medical, dental, mental health, vision, pharmacy, including contract 340B pharmacy. Remember, this is the difference, but the difference between this table and table 4 is table 4 is just the patient's medical insurance status, whereas this table is the charges and the collections for all patient services by actual payer. In column B, you'll report all the money that you collected in 2021 that resulted from services to your patients on a cash basis, meaning the money that was received in 2021. This includes reimbursement from payers, capitation payments, contracted payments, payments from patients, any retroactive settlements, receipts, and other payments you received. Also include pay for performance, quality bonuses, and other incentive payments received from payers for patient services. So for example, if the health center is involved in programs where you receive payment just for participating, meaning payments received for participation regardless of outcomes or patient volume or any patient services, or pay for reporting, meaning as long as you report a set of information, then you receive the dollars regardless of outcomes, then that's reported on table 9E. However, if the payment based on providing certain services to patients, such as case management or screenings, then it's included on this table in column B. So let's look at columns C1 through C4, which are retroactive settlements, receipts, and paybacks, also sometimes referred to as supplemental payments. The dollars reported in column C1 through C4 are included in the amount that you'll report in column B, but they do not equal column B. In column C1 and C2, you'll report the total amount of PPS, reconciliation, or wraparound payments you received during the year. In column C1, you'll report the amount you received from charges incurred in the current year. In column C2, you'll report the amount you received from charges incurred in the previous years. So for example, the last year, 5 years ago, etc. In column C3, you'll report any other payments that you receive, such as managed care, pool distributions, or pay for performance, or other incentive payments like quality bonuses, paybacks, or payer deductions by payers because of overpayments. Remember, this is all incentive payments from payers related to patient services. They don't have to be payments for patient services. In column C4, you'll report this as a positive number, any money that your health center had to pay out or that was deducted by payers because of overpayment. So in the end, column B is reduced by column C4. In column D, you'll report adjustments. Adjustments are agreed upon reductions or write-offs in payment by a third-party payer. It's the difference between your fee schedule rate and what you have agreed to accept from a third party. Adjustments are not non-payment for services not covered or rejected by a third party. They're also not deductibles. They're not co-payments due from patients. They're not allowances, and not an amount that you decide that the patient isn't going to have to pay. Initial adjustments are reduced by the retroactive payments you reported in column C1 through C3. So your wraparound payments and incentive payments. And then any paybacks that you report on C4 are added to adjustments. Your adjustments may be a negative number, and if it is, type it into the EHB with a negative sign, not a parentheses. So if you had 10,000 in initial adjustments for column D and a total of 11,000 in retroactive payments in column C1 through C3, then your adjustment would be negative 1,000. Adjustments do not typically equal the difference between charges and collections, so they don't generally zero out. This would only really be feasible with capitated managed care because they typically don't carry a balance. Sliding fee discounts in column E are only reported on line 13 self-pay. Sliding fee discounts are reductions in patient charges based on their ability to pay. These are determined using your health center's board-approved discount schedule. They're typically based on the patient's income and family size per the federal poverty level, and uninsured patients who are below 2 times the federal poverty level. Sliding fee discounts can be applied to any of the amounts of the patient's out-of-pocket costs, such as co-payments, a deductible, and non-covered services. To report self-pay charges and collections for insurance patients, the portion of the claim that's the patient's responsible for and therefore will be eligible for a sliding fee, the health center must reclassify the patient pay portion of the claim down from the original charge line to the self-pay line. Column E is only reported on the self-pay line because it's the reduction in the patient pay portion of the charges. It's grayed out for all other payers. Again, sliding discounts must be based on your discount schedule and applied at the time of service. They can't be applied to past due accounts. Bad debt write-off in column F are only reported on line 13 self-pay. Bad debt is the amount owed by patients considered to be uncollectible and formally written off during the calendar year. Bad debt can include debts from charges from previous years. For example, some health centers will even go every so often go through their books and write off multiple years bad debt, which is okay. Just make a note to your reviewer in the table comments on your report. Only patient bad debt is reported in UDS, not third-party bad debt, meaning only charges or claims on the self-pay line can be written off and therefore reported in column F payer. Only line 13 allows bad debt reporting again, and bad debt should not be reported as sliding discount. Discounts or debt forgiveness are also not bad debt. So this slide is provided mostly as a reference. It really just spells out where revenue received from various payers are reported on table 9D. Remember that table 5, this table has really 5 general sections. There's Medicaid, Medicare, other public, private, and self-pay. And then there's just a description under each. It's really, again, for guidance. There are many examples of where a patient's primary medical insurance is different from where the patient's charges and revenues are reported here. For example, a patient who is uninsured or has some other type of insurance on table 4 may have care covered by a grant program like Title 10, which is reported in other public on this table. Another example could be that a patient may have private insurance on table 4, But if no portion of the charge is covered by their private insurance, so the full charge is self-pay, would be self-pay on this table, or the patient's medical insurance may be Medicaid, but if the patient only had dental services that are not covered by Medicaid, then those charges and related collections or sliding fee would be reported as self-pay on this table. So it's just a way to give you just sort of a reference point as you're working through your UDS reporting. So this was noted on that last slide, but COVID-19 uninsured program revenue is reported under other public on this table. Note that this program is specifically for uninsured patients. So these patients must be uninsured on table 4. In the other public section of table 9D, there's now a line for HRSA COVID uninsured program reporting. This is line 8C. And like all other lines, it's required that you report full charges in column 8A, the collections in column B, and the adjustments in column D. Only claims submitted to HRSA's COVID-19 claims reimbursement for testing and treatment of the uninsured patients are reported here. And do not report any other charges or collections on this line. Other claims for uninsured patients wouldn't be reported here. So revenue for each third-party payer is generally divided into 3 forms of payment: non-managed care, managed care capitation, and managed care fee-for-service. Non-managed care refers to the payment model in which procedures and services are separately charged and paid for by a third-party payer, generally based on fee-for-service. The third-party payers pay some or all of the bill based on agreed upon maximums or discounts. It's really important to understand the payments received for services to patients who are not assigned to the health center as part of a managed care plan are reported in the non-managed care line. This means that the health center likely needs to do some reconciliation because not every receipt from a managed care organization will be reported as managed care. Only those managed care payments for assigned patients are reported as managed care. Managed care capitation refers to a payment model in which a health center contracts with a managed care organization for a specified set of services, for which the managed care plan pays the health center a set amount for each patient assigned to the health center. This is called a capitation fee and is typically paid per member per month. Managed care fee-for-service refers to a payment model in which a health center contracts with a managed care organization and is assigned a set of patients for whose care the health center is responsible. The health center is reimbursed on a fee-for-service or encounter rate basis for covered services. Note that the charges for each of these forms of payment are still reported based on the health center's fee schedule. So, although managed care capitation is paid regardless of services rendered, charges still need to be reported based on the services rendered. I mentioned a little bit about reclassifying charges. Here's an example of what that might look like. So a patient is seen at a health center, and at intake, the patient states that they still have the same private insurance plan as the last time they were seen. The patient then has a visit with the healthcare provider. And then when the health center bills that insurance for the visit, the claim is denied because the patient was no longer covered by that insurer on the date the patient was seen. So in that case, the charge that might have originally been on line 10, private non-managed care, is then reclassified to line 13, self-pay, because now the patient is responsible for that charge. And here's a case example, a scenario, to try and again, bring this to life based on what I've been sharing. So if you have, and again, you can have your UDS tables out and look at them as we talk through this, but it's really trying to connect how reporting is done across tables 4 and 9D. So this example, Rhonda is a patient at the health center and schedules an appointment for a COVID test because she has symptoms. At the time of her visit, Rhonda is uninsured. When Rhonda comes in for the COVID test, she's experiencing shortness of breath and a cough. And she's seen by a provider who takes her history, including symptoms, onset, and does a full physical exam. Rhonda's COVID test is positive and the provider prescribes Rhonda an inhaler and some medication for her cough, and the health center submits the claim for Rhonda's care to HRSA's COVID-19 uninsured program. So think about, where would Rhonda be reported on table 4? So remember, determine, what would you determine about her primary medical insurance? Then think about on table 9D, where would those charges be reported? You can chat in your responses, but we'll talk those through here. So Rhonda would be uninsured and reported that on table 4. But then on table 9D, the full charges for the COVID care she received are reported in column A of lines 8C versus COVID uninsured program. And then the amount received from the HRSA COVID uninsured program would be reported on column B of line 8C. Hopefully that example kind of tried to connect those two tables and how they would fit together in a scenario. So here's some more on 340B pharmacy in a little more detail. I know this is important for many health centers. So first, on table 8A, the costs table, you'll report the amount the contract pharmacy charges for managing dispensing of drugs on line 8A, pharmacy in column A. You'll report the full amount paid for the drugs, either directly by the clinic or indirectly by a contract pharmacy on 8B, pharmaceuticals in column A. If the pharmacy buys prepackaged drugs and there is no reasonable way to separate the pharmaceutical costs from the dispensing or administrative costs, report all costs on line 8B, associated non-clinical support services costs. The overhead costs go on 8A, even though line 8A, column A is blank. So report payments to pharmacy benefit managers on line 8A, pharmacy. And some pharmacies split the fee or keep a share of the profit. You'll report this as payment to the pharmacy on line 8A, pharmacy. Then on to table 9D, patient service revenue. The charge reported in column A is the health center or contract pharmacy's full retail charge for the drugs dispensed, reported by payer. If retail is unknown, ask the pharmacy for retail prices for the drugs dispensed. The collection section reported in column B is the amount received from patients or insurance companies. Health centers must collect this information from the contract pharmacy in order to report accurately. Adjustments, reported in column D, is the amount disallowed by third party for the charge, if on lines 1 through 12. Then the sliding fee discount, column E, is the amount written off for eligible patients per the health center policies in line 13. And that you would calculate as retail charge or pharmacy charge minus the amount that's collected from the patients and minus the amount owed by the patients. On table 9E, other revenue, you would not report pharmacy revenue on table 9E, and you would not use table 9E to report the net revenue from the pharmacy. You'd report actual gross revenue on table 9D, according to the instructions we just walked through. And again, when you get to the point where you're digging into this, this slide might be a helpful point of reference for you to look back to. So the last of these financial tables, the other revenue table on 9E. This is the non-patient service revenue. There is one new line for the American Rescue Plan funding, which was received by health centers and lookalikes. Otherwise, the remainder of table 9E is consistent with prior years. Table 9E captures non-patient service cash receipts from federal, state, and local sources. For all the income on table 9E, you'll report only the amount drawn down or actually received in 2021, not the award amount. That could be different. The main value of this data is that it permits the users to see the distribution of non-patient service revenue by federal, state, and local sources. These receipts can be combined with revenues reported on Table 9D for comparisons with national, state, and other health center groupings. This data, as is the case with the other two financial tables, is not available either from through audits or financial statements. So funds are reported from the entity from which you received them, so AKA the last party rule. So an example of this would be is if you receive funds for disease surveillance from your state health department, but you know that the funds originated from the CDC, you should report them on line 6, state government grants and contracts, because you received them from your state health department. In the first section of Table 9E, lines 1A through 1K, you'll report the total amount you drew down from grants you received from the Bureau of Primary Health Care. This includes any supplemental funds that are part of your grant that you drew down during 2021, though does not include COVID funds or the American Rescue Plan funds. Those are reported on lines 1L through 1P. For those that received CADRE, C-A-D-R-E, capital assistance for disaster response and recovery efforts, that goes on line 1K of Table 9E, capital development grants, including school-based health center capital grants. Note that HRSA knows how much more they have granted to your health center, so just be sure it's reported correctly. Last year, some mismatch in the Bureau of Primary Health Care's funding selection section led to a lot of reports being sent back. And, but we'll get into the COVID portion here in a bit, a little more. Just be sure to include the funds that you receive from the Bureau of Primary Health Care accurately, and then as best as possible. And and include those that you also receive, but then pass through to another agency. Other federal grants are reported on lines 2 through 5. Include grants you receive directly from the federal government other than the Bureau of Primary Health Care. Ryan White, Part C, is reported on line 2. This includes any COVID funding from HRSA-HAB as part of the Ryan White Part C program. Other federal programs like HUD or SAMHSA or CDC is in the other federal grant section. Ehr Incentive Payments is included as well, including promoting interoperability funds, including funds paid directly to providers and turned over to the health center, and provider relief funds. FCC telehealth expansion grants or telehealth expansion grants from USDA, anything like that, would also be reported in the other federal grants section in line 3. For any specified fields, such as line 3, other federal, please fill those out because it really helps the reviewer and HRSA understand the revenues reported on this line. It also helps make comparisons from year to year. Do your best to be specific and try not to use acronyms or spell out those acronyms that are less common. So let's get into the COVID part of the Bureau of Primary Health Care grants. It's important for each and every health center to do their due diligence to report this section correctly, as many reports were sent back for incorrect reporting last year. Note that these lines only include funding from HRSA's Bureau of Primary Health Care. No money from HRSA, HAB, FCC, USDA should be reported in lines 1L through 1Q. Line 1O is the American Rescue Plan grant funding, which was received by all health centers, those 303 funded and lookalikes. It's expected that all health centers will report dollars in this line. In line 1P, other COVID-19 related funding from Bureau of Primary Health Care, and then specify. The Bureau of Primary Health Care has not awarded additional COVID grant funding, so no revenue should be reported in this line. Again, that's 1P. You can refer to this detailed guidance for COVID funding that Brandy just chatted out to you for more specifics on that. And as I noted on the last slide, the FCC telehealth expansion grants, the telehealth expansion grants from USDA, anything like that, would also be reported in other federal grants. Also, the Paycheck Protection Program, the PPP, is a loan, and that's not reported in the UDS, even if it's forgiven. Same with any other loan that's forgiven, loans are not reported in the UDS. So state and local government. So funds received by state or local government, taxing district, or sovereign tribal entity, like WIC, those are here. Don't include fee-for-service payments like breast and cervical cancer programs or indigent care programs here. You'll report those on 9D because it's patient service revenue. The Ryan White HIV/AIDS program, that is reported in line 7, local government. That's part A. The Ryan White HIV/AIDS program, part B, is reported in line 6, state government. Part D, funding from the HIV/AIDS Bureau, is on line 3. Any foundation or private funds, like hospital or United Way, there's a section for those as well, line 8. Other revenue on line 10 includes cash contributions, fundraising income, rents received, sales, interest income, patient record fees, pharmacy sales to the public that are non-health center patients. Don't report bad debt recovery or 340B payments here. Those revenue are reported on table 9D. Oh, I'm glad you said that. Oh, there's an F missing from that last link, Brandy. I can fix it too if it may have been me sending you the wrong hyperlink, but it's the last dot PD. I think that should be PDF. So let's recap here, and then we'll do a poll. So first on table 8A, be sure to allocate overhead in a way that accurately reflects the cost of service areas in your specific health center. Ensure that you have the information you need to report 340B pharmacy accurately on table 9D. Be sure that table 9D charges are reported based on your fee schedule, and be sure that you're reporting your COVID-19 monies that your health center has received accurately. Some don'ts. Don't report patient-generated revenue, including revenue for 340B or pay for performance on 9E and so on. We went through that in a fair amount of detail. Don't forget that if there is managed care revenue on this table, that there should be some member months on table 4, or there should be an explanation. It's possible to have managed care that's not medical, therefore to not have member months on table 4, but that's pretty rare. Oh, thank you, Brandy. So hopefully, Laura, the link now gets you where gets you connected to it. So let's do a quick knowledge check poll here. Here we go. So where is COVID grant funding from FCC and or USDA drawn down in 2020 reported on 9E? And you can pick one of these options. Is it line 1O, American Rescue Plan? Is it 1P, other federal 19 related funding from Bureau of Primary Health Care specify? Is it line 3, other federal grants? Is it line 3B, provider relief funds? Or is it this revenue is not reported on 9E? And Brandy, whenever you feel like some folks have chimed in and hopefully engaged a little bit here with this. Well, okay. Oh man, y'all are on it. You're right. 67% of you, other federal grants. And I guess the only tricky part of this is that the COVID grant funding from FCC, USDA, it wouldn't be 1P because that 1P is specifically asking about COVID-19 related funding from the Bureau of Primary Health Care. But just, you know, a fun knowledge check to try and just remind you as you're going through what to be on the lookout for. So y'all are going to get so sick of me saying there's so many resources out there to support you, but there's a lot there to help you with your reporting in the financial and operational reporting. They're listed here with a bunch of hyperlinks. So the slide deck you can go back to and check those out for those helpful resources. A lot of fact sheets, and there is also a handout of common error checks. That's one here, the financial tables guidance handout with common error checks. That might be of interest to you as you're plowing through this. So, okay, folks, home stretch here. Final section here with the other forms to complete. And I hope that by the end of this, we had some chats like, oh, should we put this at the beginning of the training? Because so oftentimes people are losing steam by the end of this and, oh, the other forms. But I just want to share that these forms are still super important. So I hope you can tune in for the home stretch here. So there are 3 of these forms. The first of the 3 is the Health Information Technology Capabilities form. You're going to report this and all forms based on your health center's status as of December 31st. The Health IT form, as it's known, it asks a series of about 15 questions. And sometimes a little less or more depending on some of your answers because there's some skip logic, but it's really about your use of EHRs and health IT. The first portion of it, you'll report whether you have an EHR, what EHR that is, both vendor and product, how widely it's used, whether you use more than one system. Then you'll answer some questions about use and functionality of your health IT system. You can answer these parts of the health IT form now, assuming that you're not in the middle of an EHR switch or anything like that. The preliminary reporting environment is open. And so you could consider even testing out your login if that's something available to you and navigating that preliminary reporting environment to report on that. Then there's a social risk screening section, which asks a set of questions about social risk or social determinants of health screening. On this portion of the form, starting at question 11, this is referring specifically to screening for social needs or social risks that are not reported elsewhere in the UDS. This means that this is specifically asking whether the health center's screening for social risk beyond income, insurance, language barriers, intimate partner violence, human trafficking, as these are already reported in Table 4 and Table 3B and Table 6A respectively, it's really looking to whether the health center is screening for social risks. And if you're using a standardized screening approach, like a standardized set of questions, even if that set of questions is cobbled together from various screeners, then please do not select, we do not use a standardized screener. If a health center is using a social risk screening tool of their very own making, something that draws on several sources or a tool that's not listed as an option, then you'd select other, and then you'd provide a description. Likewise, if you're implementing one of the tools that's listed in this form, you would fill that out. Even if it's not completely uniform across your organization yet, you'll still select the tool from that list. And you'll report the number of patients who screen positive for 4 social risks. So here, I'll put that here. So you're going to report on patients who screen positive for food insecurity, housing insecurity, financial strain, and transportation barriers. Patients reported as screening positive for these 4 social risks must be health center patients included elsewhere on the UDS, meaning that these are patients reported in your demographic tables who have a countable visit on table 5. Patients reported on these 4 social risk lines must be those identified through that social risk or social determinants of health screening. Don't use proxies like low income or Medicaid or anything like that to identify patients. There's a crosswalk linked and shown on this slide, which is also freely available on HRSA's UDS website, and indicates that what questions from the different standardized tools should be used to assess each question and what should be considered a positive screen for UDS. This is really important to HRSA and the current administration and helpful in understanding the needs of patients served by health centers. And there's a, thanks Brandy, Brandy just chatted out the helpful link that you can refer to for more on that one. Telemedicine's covered in more detail on the next slide. HRSA has detailed guidance for outreach and enrollment. In the medication-assisted treatment, the MAT section, you will only report physicians, certified nurse practitioners, physician assistants, and certified nurse midwives on site or with whom the health center has contracts who have obtained Drug Addiction Treatment Act of 2000 data waivers to treat opioid use disorder on question 1A. And then only patients who received medication-assisted treatment from those data waivered providers are reported in question 1B. In the outreach and enrollment assists portion of this form, you'll report the number of assists. Remember, outreach and enrollment assists refer to education sessions provided by a trained health center assister to health center patients about affordable health insurance coverage options and any other assistance provided to facilitate health insurance enrollment. These are reported. These assists are reported here are not countable visits on table 5. They're not solely countable visits if this was the only interaction service that was provided. So in the telemedicine or telehealth portion of the other data elements form, the health center will answer 5 questions, which are spelled out on this slide. So note that the questions use the term telemedicine, by which means specific to remote clinical services. Health centers are to report on telehealth services that were in place or in use in 2021, regardless of whether those services were billed or generated countable visits. If your health center has virtual visits on table 5, then you should be reporting that, yes, they do use telemedicine to provide remote or virtual clinical care services here. The opposite is not necessarily true. Like a health center could reply yes and then provide telehealth services and not have countable visits on table 5. But for those who respond yes, there's a series of questions about for what and with whom. If you report not using telehealth or telemedicine, you'll be prompted to identify why not. Assuming no programmatic changes are underway, you can likely answer these questions on the other data elements form now on that preliminary reporting environment as well. So the workforce form. This seeks to understand the current state of health center workforce training and different staffing models to better support recruitment and retention of health center professionals. Topics reported on the workforce form include professional education and training, staff satisfaction surveys. The professional education portion asks about health centers' role in providing professional education and training. First, whether the health center is a training site partner, and then what type of training is provided, like pre-graduate or certificate training or postgraduate training. Also ask the range of staff who engage in professional education or training and the number of individuals trained at each level. Then this form asks about the frequency and use of staff satisfaction surveys. So specifically questions 5 and 6 ask, how often does your health center conduct satisfaction surveys to providers and for general personnel? These refer to specifically to survey health center staff. So just providers are in question 5 and other staff are in question 6. And it's about their own satisfaction. It doesn't refer to patient satisfaction surveys about providers. So remember this and those other 2 forms that we just went through are important and required as the 11 tables that we've reviewed. So that's the overview. I hope you're not asleep. There are, again, I'm like the broken record here with all the available resources to support you. There is a lot of information beyond these 2 training sessions available to you. And I want to highlight just a few of them for you now, especially for those of you that were in that first day training. So all the UDS resources that have been sent, they're all centralized on the HRSA UDS resources page. I've been referencing that a fair amount. So this is a snapshot of that hub. And I just want you to know that there is this 2022 section, but where you're going to find the resources related to this year's reporting for the 2021 are all here. There are recorded training modules that are available for you, and you can listen to them. This is a really good option for people that are new to UDS. And sometimes it can be hard to wrap your head around all of that. There's, it goes section by section. There's the recording. You can find these modules, especially the submission success piece here. It's a great guide. With regard to the clinical measures we went through today, there's a series of webinars that were done specifically about those clinical tables, parts 1, 2, and 3. There's a recorded webinar on counting visits. There's a recorded webinar on the financial operational tables that go in much more detail. And then again on successful submission strategies. If you come up with if you have a question that you would really like some individualized support to ask your question to, here are a slew of resources available to you to help you with your UDS submission. You can call with questions about how to complete your report. There's an 800 number there. There is the Health Center Program Support helps you with the functionality of the EHB, if there's a program or a glitch. And again, log in now if you can to make sure you can access the EHB now. Now's a good time to do that. And the HRSA call center hours are up here as well, and when you can reach out. A few other just tips for success. I hope that you've not just learned about how to complete the UDS, but some strategies to make the submission easier. The tables are all interrelated. So if you are working with a team, we've talked about which tables how they connect to each other. So if you have teammates you're going to be working with, hopefully you know which ones you will have overlapping information with. Follow the definitions. There are a lot of resources, manuals, fact sheets, that sort of thing, but really refer to those. Check your data to make sure it's accurate. Compare previous year reports and benchmarks. If they seem really, really different, check to see if perhaps there's a mistake. And address any edits, either through data changes or with meaningful explanations. And you can work with your UDS reviewer. They're there to help you. And we encourage you to communicate with them about deadlines and communicate openly. More information here, available assistance. And finally, late, inaccurate, or incomplete UDS submissions may result in program conditions. As the UDS Health Center Compliance Manual does require that health centers maintain systems that allow for accurate reporting of the UDS. All health centers submit, and that all health centers submit timely, accurate, and complete UDS reports. This is not to say that if your reviewer has questions, you're going to face program conditions. Rather, it's just you can't submit incomplete or inaccurate data just to meet a deadline. So communicate with your reviewer, and the timeline for submission, for those of you that didn't hear it on the first recording, it's the timeline is listed here, so you can review that. So I appreciate your time. I'm open to having any questions. If you have some questions, I'm open to those. You can put those in the chat box, or you can come off mute. There's a link here for evaluation. Your feedback's important to us and to HRSA. So if you can take a moment and complete that, I would greatly appreciate it. I know we have a bit of time left in our schedule, but I definitely am open if you do have questions, and we can talk through any of those together. Well, thank you all for your time, and happy holidays. And I wish you all the best with your UDS reporting. And again, lots of help available to you. So
thank you, Megan.
Yeah, sure thing. Thank you, Brandy. It was a treat working with you.
You too.
All right.
Thank you, everyone. Happy holidays.
Everybody.